All right, guys, so this is chapter 5, the integumentary system. We were just in the last chapter talking about the different types of membranes and skin and connective tissue and all that. So we'd already kind of started our discussion of the skin. So just a reminder, it's the largest organ in the body. It's also extremely thin, so it's very easy for us to absorb things, excrete things through the skin. And it's really important for us to note that it's more than just a covering for the body. Skin is crucial for human survival. Eventually, we're going to talk about burns. We are not going to talk about burns now. I'm going to focus just on normal anatomy and physiology. But eventually, you are going to talk about burns, and it'll be really important that you know how we care for these people when they do lose a great percentage of their skin, because it is such a huge part of our ability to survive. Let's talk about the different structures in the skin. So, like I just said, we had talked about the skin being the cutaneous membrane, right? And that it has multiple layers, the epidermis, the dermis, and the hypodermis. We'd also talked in the last chapter about epithelial tissue and how epithelial tissue is part of the skin. So lots of different things here. But let's start with the different layers of the skin. The first layer there is the epidermis, and it's really the outermost layer. It consists of stratified squamous epithelial tissue. It also contains no blood vessels, so it receives all of its oxygen and nutrients by diffusion from the dermal layer, the dermis. Again, important for us to note, we have to have that functioning, the dermis functioning, in order to supply nutrients and oxygen to the epidermis. The dermis is composed of connective tissue, so not epithelial tissue, connective tissue. It contains primarily collagen fibers, which strengthen tissue, as well as elastin fibers, which add elasticity, and reticular fibers, which bind collagen and elastin fibers together. So we talked about all of those things again in the last chapter. The dermis has a huge abundance of blood vessels, plus sweat glands, sebaceous glands, nerve endings, and hair follicles. The papillae extend upward from the dermis, where it interlocks with the downward waves projecting from the bottom of the epidermis. And you can see this here, these waves here. That's what actually binds these two layers together. So we have this kind of wavy area that creates projections into the epidermis and the dermis, and they can bind together that way. The hypodermis is made of areolar and adipose tissue, and it binds skin to underlying tissue. So it's kind of the third layer there. You can see it kind of down here, all the way at the bottom. It's important that it's there for a variety of reasons. Again, remember that adipose tissue means subcutaneous fat. So when we talk about subcutaneous injections, we're going to talk about putting that medication into this area. It also helps insulate the body from the outside, and it also acts as an energy reserve. So we need all of those things to help our body maintain its normal homeostasis. Some different layers of the epidermis. Now we're talking about just that kind of top upper layer, just that small little layer of epidermis. There's a couple of different layers happening here. We have the stratum corneum and the stratum basal. So what kind of happens here is that we get new cells being formed down here at the bottom, and they push their way up here. Once they get here, really, they're dead, and they're just waiting to kind of be sloughed off. They continue to go, these cells continue to go through mitosis and reproduce and divide, and they just keep moving up. We shed a ton of skin every year, to be exact, or more precise, about a pound of skin every year. So that's a ton of skin. And in different areas of our body, we're going to see different varying degrees of this stratum corneum. Things like heels, palms, we have more layers because we need those areas to be a little bit more durable, or able to take a little bit more kind of abuse from us touching things and handling things and walking on things. We also get keratin here. So as the cells are pushed upward, they stop dividing and instead produce keratin, a tough fibrous protein. The keratin replaces the cytoplasm and the nucleus in each cell. The cells flatten as they move away from their blood supply. They die. So this is really where there's a lot of keratin, which is that protein that we talked again about in the last chapter. I want to show you a quick animation here. Unlike our last chapter where we had tons and tons of animation, last week's, these two lectures this week really aren't going to have too many animations. Much more factual information versus conceptual information.
During the course of life, the cells of the outer layer of the epidermis are sloughed off. This means that the skin must continually renew itself by replacing the sloughed-off cells with new ones. Those new cells are created in the lowest level of the epidermis, the stratum basal. The stratum basal consists of a layer of columnar stem cells. These stem cells continually undergo mitosis, producing new skin cells. As new cells are produced, they push the older cells upward toward the skin's surface. As the cells are pushed upward, they stop dividing and instead produce keratin, a tough, fibrous protein. The keratin replaces the cytoplasm and nucleus in each cell. The cells flatten, and as they move farther away from their blood supply, they die. By the time the cells reach the outermost layer, called the stratum corneum, all that is left of the dead cells is their keratin. The newly arriving flattened cells, called keratinocytes, replace the dead cells that flake away with daily wear.
So just kind of reiterating what I just said about the cells moving upward. I think that was a really nice visual though. So let's talk a little bit about skin color. So we have melanocytes, are cells that produce melanin. They are located throughout the basal layer of the epidermis. And then the melanin accumulates in the epidermis. So the melatonin really, its goal or its kind of job is to protect the nucleus from ultraviolet exposure. So it does have a protective mechanism. The amount and type of melanin determines skin color, not the number of melanocytes, but the amount and type of melanin. So on page 71, you can see this diagram here I have on your slide in a little bit better detail, probably on your big screen. Hopefully you can see it pretty good. But we know that cells in darker skinned people produce more melanin, and the melanin is broken down more slowly, hence why their skin color is darker. In this diagram, though, it shows you actually a melanocyte in that epidermis layer, and that kind of that picture we just saw with the different layers of epidermis. They really have these long projections reaching between cells, and that's where they release the melanin. The keratinocytes then bring the melanin into their cells. The melanin forms a protective cap over the top of the cell nucleus and protects it from exposure to harmful UV rays of the sun. That's why we see skin cancer being a little bit less common in African American people or people with darker skin. They have more melanin, so they have more of a protective mechanism. Versus people who have really, really, really fair skin, they tend to be the people that have increased risk for skin cancer. Also want you to note on page 71 the different abnormal changes in skin color. So I want you to star a few that I want you to definitely know. Cyanosis is one. It really just means that the skin has a blue tint to it, and the cause is generally a deficiency of oxygen in circulating blood. Jaundice, on the other hand, is yellowish discoloration of the skin and the whites of the eyes, usually related to liver impairment. Erythema is related to or looks like abnormal redness of the skin. Lots of different reasons here. It can be a rash, emotion, sunburn, exercise, heat, dilated blood vessels, lots of different things that cause erythema. Pallor is pale skin, usually caused by decreased blood flow, sometimes from cold temperatures, fear, emotional stress, things like that. And then bruise or hematoma is a bluish, black, or yellowish mark on the skin. So we're all probably somewhat familiar with that, and that's really just related to a breakdown of clotted blood under the skin. Functions of the skin. So, did touch base on this a little bit in the last chapter as well, but hugely, the skin is a protective mechanism for our body. So, it prevents microorganisms and chemicals from getting into our body. It secretes a residue or film that blocks toxins and bacterial growth. It is also a barrier, so it blocks UV radiation. We just talked about the melanin doing that, and it really helps to keep water in and out. That top layer of the epidermis that we talked about, the stratum corneum, really provides that kind of water resistance, but it also allows water to escape from the body when need be. It plays a role in vitamin D production, so it initiates vitamin D production when exposed to sunlight, so it's very big in that. And people who tend to live in our area or our part of the country often have vitamin D deficiency because we spend a lot of our year without a lot of sunlight. Skin also plays a role in sensory perception, contains nerve fibers for temperature, pain, pressure. I mentioned in the last chapter as well about touching a hot stove, right? So you have to have this sensory perception in our hands and our skin to tell us when there's been a change or there's a stimuli that we really need to react to. And then skin also plays a role in thermoregulation. So it controls heat loss or helps to retain heat, and it serves both of those things. So it can help us hold on to heat if we're cold, and it can help us get rid of heat if we're too hot via sweating. Just on another note too, skin can absorb medications, and I talked a little bit about this already. It has that ability. So we will discuss transdermal medications, meaning medications that can be absorbed through the skin. So we can put patches, lotions, creams, anything like that on. It's considered a medication because it's being absorbed through the skin. But on that same note, skin can also absorb toxic chemicals. So we have to think about really what we're putting on our skin or on our hair or any of those types of things. I want to talk about a few appendages of the skin, and those are hair, nails, and glands. So hair, we really should all be familiar with what hair is because all of us have it to some degree. It occurs everywhere in the body except for a few locations: palms, soles of our feet, lips, and some areas of the genitals. Some hair has a protective role, especially on our face. So our eyelashes and our eyebrows keep sweat, dirt, debris out of our eyes. And nose hairs keep debris out of our respiratory tract. The rest of the hair on our body really has no function. So let's look at this diagram here and talk about the hair follicle. So the hair shaft extends above. The hair shaft extends above the skin surface. So that's the shaft. It's the only part you can see above the skin surface. Each hair lies within a sheath of epidermis called a hair follicle. Hair follicles have a rich nerve and blood supply. The follicle continues to go down. It's buried in the dermis and becomes the hair bulb or hair root. This is the lowest part of the hair and is where growth occurs. So this is where mitosis is happening, and it's pushing the hair up. At the base of the hair is a cluster of connective tissue and blood vessels called the papilla, and that's really what brings the nutrients to the bulb and the root, allowing it to go through mitosis and push that hair up. Attached to each hair follicle is a small bundle of smooth muscle called a pili muscle. Cold temperatures or emotions such as fear cause the muscle to contract, and when it does, the hair becomes more upright, sometimes called standing on end. We can think about this, especially in dogs. It's really easy for us to see this happen in dogs. So again, just a reminder here, the shaft is above the skin, comes down to the hair follicle. Below that is the bulb. This is where growth occurs, and it pushes the hair up. This hair follicle and this shaft is really dead tissue. Down here is where the growth occurs, and it pushes the dead tissue kind of up. The papillae is where the nutrients come in. So you can see the vein and the artery here coming in, and that's what's bringing nutrients to the hair follicle and hair bulb. Hair color and texture. So some of us might think, well, geez, why is it different for some and not others? It really depends on the type of melanin. So we have eumelanin and phyomelanin, and it's just kind of part of genetics. So dark shades are eumelanin, blonde is phyomelanin, a red is a combination And gray or white is a lack of melanin. So we can see here that these people have very different hair. In the shaft, that's an error there. The shaft of the hair follicle determines straight or curly. So it really depends on kind of the size. If we have a round shaft, it's considered straight. If it's an oval shaft, these people are going to have curly hair. So it's the shape of the shaft, and that's what that should say. The shape of the shaft determines straight or curly. Let's talk about hair growth and loss quickly. All cells of the hair other than the cells about the papillae are dead cells, and I just mentioned that. They're filled with keratin just like our skin. So as our skin cells move up, you can think about hair growth just like that. Hair lives 2 to 6 years and then falls out. So in those years is when the hair grows, and depends, everybody's kind of grows at a different rate. Some people's hair grows really fast, some people's don't. It's kind of a genetic thing. Excessive hair loss means, or the term for that is alopecia. Sometimes it happens for reasons like chemotherapy, poor nutrition, emotional distress, pregnancy, aging, any of those things. Sometimes we have something called male pattern baldness, and that's really an inherited gene that causes alopecia. The nails are also an appendage of the integumentary system, so it's important that we talk about it. We know the different areas here. Nail body, the cuticle, this is the edge. The lunule is this white area that's at the base of our nail. We all have it. All looks a little different on everybody. That's where new growth is occurring. So you'll see that sometimes if people damage their nails, they might have these little, different white spots on their nails in varying places. And that's where new growth is occurring. So nails consist really of densely packed, heavily keratinized epithelial cells. Again, no surprise, these are not really living type cells, kind of like our hair and our skin. The nail body is the visible part of the nail. The cuticle is a fold of skin surrounding the nail body. And the lunule is that crescent-shaped white area at the base of the nail where the new growth is occurring. The nail bed is a layer of epithelium underneath the nail. It normally appears pink because we have a ton of blood supply there. And it's important that we note this because eventually we will be looking at people's nail beds for circulation. And we'll also be checking for pulse oximetries or oxygen saturation levels using this capillary bed. So it's one of our kind of assessments or data collection areas. The nail root is the proximal end of the nail and is really hidden underneath the overlying tissue. So you can see it here. We can't see that on ourselves. Nails grow as newly keratinized cells are added to the nail root from the nail matrix, and as the new cells are added, the nails push forward. There's lots of different things that can cause variations in the nails, and again, there's a table on chapter 47 in your book that talks about some of these. I really just want you to note 2 of them. Clubbing, you don't have to kind of commit this to memory, but I want you to be familiar with it because we will eventually talk about it later on. And it's really related to long-term oxygen deficiency. And then cyanosis, just like cyanosis of the skin, we have cyanosis of the nail bed. And again, it's often the first sign of an oxygen deficiency. So we'll really want to be looking at the nail beds and being able to note if we think people have good circulation or if they have good oxygenation to that area. I want to talk just about a couple of glands and then we're all set. So we have a couple of different types of glands in our bodies. We have sweat glands and we have ceruminous glands. So under kind of the category of sweat glands, we have eccrine glands, apocrine glands, sebaceous glands. There are 2 main types of sweat glands are eccrine glands and apocrine glands. Eccrine glands, they contain a duct that leads from a secretory portion through the dermis and epidermis onto the skin surface. This really is where we sweat from. So we, these glands help us to maintain our body temperature. If we're too hot, we sweat. That water is excreted onto our skin, air goes over it, and it cools the skin. So that's how we maintain a constant core temperature. It also can help us eliminate body waste if need be. It's not often our first way that we would go about that, but if our first way, which is our urinary system, isn't working properly, we may go about excreting some waste products through these eccrine glands. The apocrine glands, on the other hand, contain a duct that leads to a hair follicle. So instead of opening to the skin surface as the eccrine glands do, they go to the hair follicle. These are located mainly in the axillary and groin regions. They're really considered scent glands. They respond to stress and sexual stimulation. They don't begin to function until puberty. And the sweat produced here does not have a strong odor unless it accumulates on the skin, when this occurs, bacteria begins to degrade substances in the sweat, resulting in body odor. So most people, if they have good hygiene, really aren't going to have an odor about them because they're not allowing the bacteria to accumulate. So two really different types of glands, but both still kind of sweat. Eccrine is more associated with body temperature and sweating. Apocrine is more associated with kind of emotional stress or sexual stimulation. Sebaceous glands, on the other hand, are talked about here. They're not really truly a sweat gland. They're attached again to the hair follicle, and they secrete an oily substance called sebum. Excuse me. The sebum helps keep the skin and hair from drying out and becoming brittle. So it's just kind of a substance that's secreted onto the hair follicle and onto the skin. You can have disorders of sebaceous glands, which we will talk about later on, but it's not really something that certainly is life-threatening or causing a lot of morbidity or mortality, but sometimes can be embarrassing when people have issues with these. Sebum production increases during adolescence, and when this begins to accumulate, it's when we get pimples and blackheads and really get acne. So that's why it's more of an embarrassment for people than actually a problem that's going to cause somebody some huge health concerns. The last thing I want to talk about is the ceruminous glands, which is really easy and straightforward. They're in the external ear canal, and they secrete a waxy substance called cerumen, which is earwax. That does serve a purpose. We should not clean all the earwax out of our ears. It keeps our ear canals from drying out. And if too much accumulates and dries out, we can actually diminish our hearing. That being said, sometimes people do have issues where they do need to have their ears cleaned, or we might have some elderly people who aren't being showered all the time, because often we get the earwax out when we get a nice hot shower with shampoo on our head. That's when we get this kind of dissolving of the wax and excess wax comes out of the ear. So if we have people that aren't doing that a lot, like nursing home residents, they might get a buildup and they actually start to not be able to hear. And then we have an ear, nose, and throat doctor come and actually can retrieve some of that earwax out of their ears. Okay, guys, so that finishes up this chapter. So again, remember, this is just lots and lots of memorization. Not a lot of big concepts here, just memorization. So flashcards, 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 any way to help yourself remember these. We will talk in class, about some of these concepts, and really just going to be me helping to kind of quiz you and go through some stuff to familiarize yourself with it again. But bring your questions to class if you have any questions.